Facebook Live? Oh, yes, it is. So I'd like to welcome you on behalf of the BC Pediatric Society and give you one quick instruction before we introduce our speaker, which is that those little things in front of your seat, that's how you ask the questions. You touch the white part. It's really important to do that because we're recording the session. So if you don't touch the white part, probably we'll be able to hear you, but in the recording, your question won't be clear. So I really appreciate it if you could try to remember to do that. Not that that usually happens, but one never knows. Okay, Nita.
Good evening, everybody. It's my pleasure to introduce Dr. Diane McIntosh. Sorry, she didn't want me to give you all her bio information, but I actually think it's really important in understanding who she is, so I'm going to tell you a little bit about her. Dr. McIntosh graduated from Dalhousie University, where she completed her undergraduate in pharmacy and medical school training, and then 2 years of pediatric residency followed by adult psychiatry residency. She is currently a clinical assistant professor at UBC and has a community psychiatry practice. She is extensively involved in continuing medical education programs to colleagues nationally and internationally, with a focus on rational pharmacology. She has a particular interest in neurobiology of mood and anxiety disorders and ADHD. Dr. McIntosh is the co-founder of SwitchRx, the online psychotropic switching tool. She has her own continuing medical education program called Psyched Up, developed to encourage appropriate, rational prescribing of psychiatric medications. She has published blogs in the Huffington Post focusing on mental health issues, and most recently she's the co-founder of We Do Matter.org, which advocates more compassionate care for psychiatric patients and their families. I came across Dr. McIntosh's name when I read her excellent op-ed piece in the Vancouver Sun last November, which lamented the stigma and underfunding of psychiatric disorders in British Columbia. Her articulate and impassioned plea asking physicians to speak up and demand better from our government left a huge impression on me. It's an honor to welcome Dr. McIntosh.
Well, hi, everybody. Hopefully I'm allowed to stand around here. I know I have a limited range here. So I have a lot to tell you tonight. So thank you very much for coming. The first little bit of my talk is going to be, well, a little bit about what I'm doing and encouraging you to join me. But I'm going to start off, of course, with my disclosure. I work with every company that has a pharmaceutical agent on the Canadian market. And I used to kind of show this as a slide of shame, like, oh, I'm working with evil pharma. But you know, I do not do that any longer, and I want to tell you why. The reason is that the medications that we have in psychiatry, if I'm honest, suck. We do not have great treatments. We do not have disease-modifying treatments in psychiatry. I'm very jealous of the rheumatological colleagues that we have that have monoclonal antibodies, right? You can be covered in psoriasis your entire life and have a course of monoclonal antibody and actually have clear skin for the first time in your life, change rheumatological and other inflammatory illnesses. And if you believe, like I do, that depression, anxiety, chronic psychiatric illnesses are inflammatory illnesses with the same inflammatory cascades, we need a monoclonal antibody in psychiatry, and I believe that that's going to happen, but we're not going to get that without active pharma. Now, pharma has behaved very badly in the past, and in fact, doctors have behaved very badly in the past, so what we need is very well-behaved pharma and very well-behaved physicians. Whenever you have a disclosure like I do, you also have to mitigate that disclosure. So I'm going to tell you that I will use generic names, and I think everyone here is a physician. Often my audiences are a mixed group, so a lot of our colleagues don't know all the different, so I tend to use both. Also, when I'm talking, and I don't think anything I'm going to talk about today is about on-label or off-label, but I do try to remind people psychiatry is all about off-label treatment, so I do have to talk about that a fair amount. But I think the most important thing that I want to tell you is treat your patient, the human being that's in front of you with their unique brain. I have people on MAOIs and I have people on brand new medications. And my job is to, I'm walking away from where I'm supposed to stand, my job is to fit the drug or the treatment to the patient, not the patient to the treatment. So as long as we always keep the patient in the forefront, everybody wins. All right, so just a couple seconds about me and some of the stuff that I work on, because there may be some value here. SwitchRx, has anyone used SwitchRx at all? So come on, Dean. So we have 23,000 people across Canada using SwitchRx, pharmacists, psychiatrists, family practitioners. And we started Rick Precision, who probably, do any of you know Rick? Because he works here, but not in children's, right? Rick, you know, of course, he's a PharmD. And we started this in 2011 because of people switching antipsychotics. And you know, if you ever switch from, say, quetiapine over to aripiprazole, you will know very well the challenges of doing that. But unfortunately, anytime you do a switch and there's a problem, what do you blame? The new kid, right? I could sleep before, and now you put me on aripiprazole and I can't sleep anymore. So you always blame the new one. So the idea behind SwitchRx when we started was to tell people, think about the drug you're stopping, not just the drug you're starting. Over the last few years, we've added antidepressants, combined strategies. We do have children and all kinds of different special population stuff. And the last thing we added was weight management just a few months ago. You know, we cause a lot of weight problems in psychiatry with our treatments, but remember that schizophrenia, bipolar, depression, all cause metabolic syndrome. They're all associated with metabolic syndrome just by the fact that you got the disorder. So we have to be thinking in psychiatry, if we're causing it, how do we fix it? So that's why I've added it. If you do go on, and every single page will be a place where you can click for feedback. So if you find something you don't agree with, you want us to add, you've got ideas for us, we want to hear, we respond. The next thing is my CME program, and more than anything, I'm interested because I've been doing this for the last year across Canada. I've done 12. And recently, I've had a couple of requests to do a pediatric-specific one, and so it would be interesting to see if you're interested, especially after you've listened to me babble on for an hour. This is, I started this really for family doctors. They do 80% or more of the psychiatry in this country, but they're not well equipped to do so. They're not trained in psychopharmacology the way they should. And so the whole idea behind this was rational, confident psychopharmacology. It's all about, because I believe in psychotherapy, believe me, it has an impact on gene product, but if you're a psychiatrist, you need to know your way around a prescription pad and very well. We're the people who should know how to do this. And so the idea was to get family doctors in. Much to my surprise, half of the people that show up are psychiatrists, and we do spend a fair amount of time talking about ped psych and pediatric issues. So we are, we as me, I do it the whole day. It is accredited for family practitioners, for specialists, and I have a couple in Vancouver and one in Okanagan. If you're wanting to buy some wine at the end of June, you're welcome. You can write the talk off. The last thing, I have a book coming out soon. I am in the midst of book hell right now, I will say, with the final edits. And as you can see, I don't have a really important quote at the top, so I stuck my mom up there. But hopefully someone important sometime will read this book and like it as well. What it is about, as you can see, is about depression. It's written for people who have depression, love someone who has depression, wants to learn more about depression, and it's everything I could think about with depression. Inflammation, epigenetics, and every one of you hopefully has read about epigenetics, the impact of early life experience on later life psychopathology. That's enough about me. What am I going to talk about? So I'm supposed to read you all the big objectives, but I've brought them down to 3 little pearls here. Is ADHD real? Should ADHD be treated? And does the Therapeutics Initiative offer valuable insights to BC physicians? That's what I'm going to cover. Now, I'm going to start by telling you about a case, and this is Robert. So he's a late October baby. His first words were at 9 months. This kid never stopped talking from the moment he started saying some, more, and tray. That's how he started life, was asking for more food. Whoops. He demanded attention. Not only did he want to be fed all the time, he also wanted to be sung to and read to, often simultaneously. He also refused a nap. He was a talker and a non-napper, that's for sure. So he started school a month before he turned 5, and so that meant he's always been the youngest in his class. He was very social. This was a little king of Kensington. Everyone, hey, how's it going? Have you lost weight? This was Robert. So his parents could not imagine holding him back. No one knows who King of Kensington is, right? Except for the older amongst us. There you go. His early school performance I would describe as uneven. If he loved something, he rocked. Anything that he required to do any effort at all, this was something he would not do. Learning to ride a bike, impossible, because it was just too much effort that was required. He was never a difficult kid, a disruptive kid, never got into any trouble as far as fights or big temper tantrums, but his father described him as an outspoken and determined self-advocate, which I thought was an awesome quote. He was all about him and the quality of his life. So his parents started to become concerned about him with his school performance. Homework was absolute nightmare. Math was difficult, but those fine motor skills, no cursive writing, everything had to be printed. And he is 5.5 years older than his sister, and so she did all his coloring for him throughout elementary school. His sister could stay in the lines, and even when he finished elementary, he could not. While in elementary school, the other parents and some of his teachers viewed him as being less intelligent. He wasn't a very smart kid, is the way they saw him. He had a big family history on both sides of ADHD. His dad, not a big fan of the idea of a diagnosis or treatment. Finally, when he was in grade 5, his mother talked the father into maybe getting an assessment. He was diagnosed by a pediatric psychiatrist who treated him, and instantly, the parents didn't tell anyone, including the teachers, instantly the world changed. He went from B's and C's to A's. His confidence soared. By the time he graduated from grade 7, he was valedictorian, to the shock of half the parents in the class who thought that he was a little slow, and won the award for the most well-rounded student. So this is the view I'm coming in to this, because this is my son, and he has ADHD. And he said to me when he was 13, he said, do you think that my sister, Shannon, he didn't call her my sister, do you think Shannon, who's 5.5 years younger, has ADHD? And I don't think so, strangely, because we got it all over the place. And he said this to me: please don't do to her what you did to me and wait so long to treat me. That was the worst thing to hear. But man, did that stick to me. And I say that, I don't share all the time. This is an important topic to me because it really hits home. I have a brother and clearly a long family history. I have a husband and lots of family history on the other side of ADHD. And I didn't learn anything about it in peds. It was just a kid disorder that everyone grew out of. Even when I was in ped psych, it was a childhood disorder that somehow at a neurodevelopmental disorder, it suddenly disappeared. It's not true. And now we've got a ton of science to back it up. You guys know more about ADHD than I do. So what I'm going to do, I treat a lot of ADHD, but I treat a lot of bipolar and everything else. You guys are the experts. So what I want to bring to you is the newest stuff that I could find. Sure, the last thing on earth you want to do is sit through another ADHD talk. I want to provide you with the newest stuff that I could find that's interesting. So let's start off with, is ADHD real? Or is this the new lifestyle disorder, right, that everyone's got, which I think a lot of people believe that this is a lifestyle disorder. My kid is disruptive, so I'm going to drug him so he doesn't disrupt people any longer. Now, I know no one here is from 1775, but you may remember some of this stuff, which is the first time that this was described in the literature was actually a German physician who first mentioned ADHD. And then following that, in a Scottish textbook, probably you remember from your training that Fidgety Philip and Johnny Head in the Air. Do you remember those cartoons that were drawn, the sort of early ADHD? And then in a French medical textbook, in a French literature, followed by, this is interesting, in the Lancet, which of course we all view as a very important journal, defect of moral control. I worked for the military and the Canadian Forces for several years as a civilian, and I remember going to a VAC, Veterans Affairs meeting, and one of the guys around the table said, you remember back in the day when in the medical charts, when someone had PTSD, they had LMF written in their chart? Low moral fiber. That's how people used to be referred to. So when I saw this, that brought me back to this, morals and an inability to contain your moral behavior. So in 1930s, you remember this, you probably remember Bradley and that quote about, if not for how excellent Benzedrine was, we would all be very disappointed because it beat the crap out of the 50 people that were working so hard individually with each patient in improving their skills. And then a drug comes along and it knocks everything out of the park, right? So that was the first use in these kids who had inability to to pay attention. ADHD symptoms were described in the 1940s as minimal brain damage. The FDA approved methylphenidate first, but it was for depression and narcolepsy, and then 10 years later, it was indicated for behavioral disorders in kids. And that was the sort of start of the parents training, how to be a better parent for a kid who had this hyperkinetic or misbehaving, difficult children, behavioral disorders. In the 70s, DSM-2 with the hyperkinetic disorder. Then we go into DSM-3, which starts to have this operational diagnostic criteria. Then we start getting those twin studies, 85, 95. Lots of stuff starts happening. We got the DSM-4. We've got all, clear criteria. Adults start to be recognized. Then it starts to be recognized as a serious long-term health problem. This was at the end of the 20th century and the beginning of the 21st century. And then, of course, the changes we've seen in the DSM-5. So this disorder has not just sort of popped out and it's sort of a new lifestyle kind of thing. We've been talking about this for a very long time in the medical world. You know these trajectories. This is kind of I'm going to show you little lines here to explain what all this mess is. That's the diagnostic threshold. So it changes over time, the big red line. And typical development is down at the bottom. Kids do not have ADHD, except that small percentage of 5 to 8%, different numbers, but in general around 5 to 8% of the population. The classic remitting that we see with most people is they start off with ADHD, and once they hit their later teens, their symptoms tend to get better and they don't meet the full criteria. Persistent ADHD goes along the top there, and they actually threw in the brain injury at age 24 to show that we see a lot of kids who have a presentation that looks very much like ADHD associated with a brain injury. What we know is even though you may not meet the diagnostic criteria anymore, and really a small percentage of individuals once they're adults meet the full diagnostic criteria, but they still have impairing symptoms. And they still, that functional impairment continues despite the fact that they might not meet the full criteria anymore. I don't need to tell a group of pediatricians this, but I'm trying to build an argument here. We're going towards a crescendo. Heterogeneity is really part of the nature of developmental disorders, right? It's not just ADHD, but all developmental disorders. They don't present exactly like this. Everyone is a little bit different. And we know that in ADHD that's the case as well, and it's related to the fact that there are different neural networks, different neural mechanisms, different cognitive deficits. So every individual, just like every individual who's depressed or has schizophrenia, looks slightly different. We have ideas of what ADHD is, but every person that you meet is somewhat different and has different experiences. And of course you know that ADHD changes as you age through development, right? So most children are more likely to have the hyperactive behavior. As they get older, the inattentive comes to the fore and they get into more trouble with paying attention at school. In their late adolescence and adulthood, really it's the inattentive that sticks. But something we don't talk about a lot is the fact that the emotional lability really can become the greatest burden of ADHD as kids get older. They're irritable, they're very quick to respond with frustration, and it actually may dominate the clinical picture. So you're not even looking for ADHD. All you see is this irritable or almost dysthymic or labile individual and not maybe even thinking about the ADHD. That's why the DSM-5 switched from these subtypes, right? You're predominantly inattentive or predominantly hyperactive into this sort of clinical presentation. And I think that across psychiatry, we're seeing this sort of dimensional view of mental illnesses rather than being categorical. And I really love this quote, which is why I stuck it in here. The current state of the art in the understanding of biology of brain disease underscores the notion that neurobiology couldn't care less about how we categorize neurodevelopmental disorders or psychiatric disorders. Your brain doesn't care. Your brain is doing what your brain is doing. And we have to stop thinking about, okay, are they in the D7? Are they exactly there? And treat the human being who's in front of us and their presentation and how it's affecting their life in all realms, right? So this is the hottest thing to me that I have read over the last week about ADHD and what's new here. And I'm happy to share a PDF of this so you can see all the references. But we know very clearly that every psychiatric illness is biopsychosocial, right? There's nothing that's 100% genetic. Environment, psychosocial environment is very important. And that has, even the psychosocial side has an impact on brain structure and brain function. I'm going to give you, because I know when I'm reading things, I got to remind myself of definitions. So I'm going to give you some definitions as we go along to remind everyone. But ADHD is a great example of polygenic inheritance. And that means that the expression of a phenotype, what you see in front of you, is actually determined by probably many genes. And I'm going to show you some exciting evidence to prove that. But what we know is that unlike Huntington's, right? You've got that dominant gene, you're getting Huntington's. With a polygenic inheritance, what you have is many different genes or loci that are contributing, and there's a cumulative effect. So a kid may have a couple of pieces of gene, couple of different pieces of gene. Well, they may have a milder ADHD, but a kid who's hit with a whole bunch of different pieces of gene, those guys are going to have a more serious illness. They're going to have a more difficult to treat illness. There's none that are dominant or recessive. It's a cumulative effect. So you've probably seen this slide before, the mean heritability of ADHD. So there's panic, schizophrenia, and there's height. Never forget, ADHD and bipolar are our two most heritable psychiatric illnesses. People tend to think about ADHD as a social situation. It's not. This is a highly heritable disorder. And a couple of facts around that, there are more than 30 twin studies showing the heritability is around 70 to 80%. I just want to remind you, many of you know this, but heritability does not mean 70 to 80% of someone's ADHD is inherited, and the other 30% is because you had a crappy mom or you didn't eat enough kale. That 70, 80% really means how much of the phenotypic presentation in your community is related to how much of the phenotype is related to a particular genotype in your community. So it's really a complicated definition, but it doesn't, you can't draw 70 to 80. The way that I compare heritabilities is to say, what are the heritabilities of other psychiatric illnesses, right? And schizophrenia is less. If you have two identical twins with the exact same DNA and one has one has schizophrenia, what's the likelihood the other twin will have schizophrenia? 50%, right? And so we know that these are biopsychosocial illnesses and heritability is important. More heritable is ADHD. In fact, when you look at the environmental risk factors in a family, they don't mean anything within families, surprisingly. If one sibling has ADHD, the other sibling has ADHD because of genetics. Environment is not important between siblings. We know environment is out there and it's important, but most important within families is the genetic load. And there's lots of twin and family studies showing what I know you all see, which is the comorbidity of psychiatric illness. I see it probably more than you do because I'm an adult psychiatrist. So I see someone who comes in with bipolar, and then I identify the ADHD. Well, they got bipolar, anxiety disorders, and then I identify the ADHD because comorbidity increases as people get older, right? So this is the most exciting part of what's happening, not only in psychiatry, but every area of medicine. And this is big data analysis, right? What they do now, what they can do with computers, is they can take huge, massive data sets, and they can pull that information out and understand heritability. It's incredible what they can do. So Taylor et al., there's a very large, as you know, those Scandinavians and their numbers. So the child and adolescent twin study out of Sweden, and they were able to, using this big data analysis, basically prove this neurodevelopmental theory of ADHD. They were able to show that by the persistence of the cognitive, behavioral, and psychosocial disorder throughout the lifetime is actually related to neurodevelopment. They were able to prove that with this large study. So I just want to remind you of some of these definitions. Remember loci, right? So we have two chromosomes, one from mom and one from dad, right? And you have two loci. So if you have a blue-eyed locus and a brown-eyed locus, what kind of, or loci, what kind of color eyes do you have? Brown, right? And you have two blue, then you have, and if you have two brown, you have brown, right? Okay, so you have, those are made up of genes and you have different traits. The other thing I want to remind you of are what are SNPs. And SNPs are single nucleotide polymorphisms. So those are just changes in a single nucleotide. So you remember we have G, C, A, and T, and sometimes just a single nucleotide is replaced. And that's what they look at, is these different SNPs when they're trying to identify in populations different kinds of diseases. Some of those SNPs cause nothing, but they're very helpful in trying to identify disease risk. So this is, I took this actually from a website that does genome-wide association studies, so I thought it was a really good example of how this works. So what they do is they put a little chip on these little SNPs, and they can look at, it says up to 5 million. In fact, the study I'm going to show you looked at 10 million different SNPs. So you have one population that has ADHD and the other population that doesn't, and they label these SNPs, and in the first group, they see the people with the disease and the people who don't have disease, they look the same, right? The next group, same thing. There's a whole bunch of people that have that little SNP, whether you have the disease or you don't have the disease. But for the final SNP they look at, a whole bunch of people have the disease and barely anyone who doesn't have the disease has the SNP. That is an important SNP, right? Does that make sense? Okay. So ADHD genome study, this was just published in January 2019. And what they analyzed was 10 million different loci. That was more than 55,000 different individuals. 20,000 of them had ADHD, 35,000 controls. There were more than 80 sites, and they were from around the world. So Canada, different countries in Europe, US, and China. And this is what they found. 12 specific fragments of DNA that were related to the vulnerability of ADHD. That is powerful. This is a genetic illness. They were able to identify these 12 different specific fragments, and what I told you earlier about polygenic inheritance, the more SNPs you got, the more little pieces or fragments you got, the more likely you are to have ADHD, and if you got a whack of them, you got bad ADHD, difficult to treat ADHD. So some of the key fragments, which I think is so exciting because you know the disease, you know the phenotype, the individuals are sitting in front of you, when we know that some of the SNPs are related to language development. And this particular one, this FOXP2, it codes for synaptogenesis, so creating those neuronal synapses and learning. Then the next one is centrally important in dopaminergic neurotransmission, and of course all of our medications for ADHD target dopamine. The next one, this one is expressed during embryonic development. You're still inside and stuff is happening with your ADHD, and it's important for the neural branching, right? The dendritic arborization. So again, the connections between neurons. So just remind you, genotype, phenotype, I know most people know this, is what your genes are, and you turn out to be an elephant or a person or whatever. Well, this was one of the most exciting parts that they found with this massive gene picture was the genetic correlates of a number of phenotypes that we see with ADHD. So ADHD was positively correlated with depression symptoms and major depressive disorder, obesity, increased BMI, childhood obesity, type 2 diabetes, hypertriglyceridemia. This was clear. You can see this is a significant findings for these, what we see all the time in our patients when we now have genetic correlates for individuals who have ADHD. It was also negatively correlated with subjective well-being, childhood IQ, years of schooling, and your ability to complete university. A couple more here, correlated positively with ever having smoked, the number of cigarettes you smoke every day, the likelihood of having lung cancer, and the number of kids you ultimately have, which means you want to have 3, but you only have 1. Your likelihood of being able to create a family is reduced, the genetic correlation, but I know no one will be surprised with this, negatively associated with the age that you have your first kid. You're more likely to be 15 or 16 than you are to be 35 when you have ADHD. So what we see with those ADHD patients, the phenotype that we see is that the educational outcomes are poor. They don't go as far in school. They're more likely to get kicked out. They've got criminal issues. They have major depressive disorder and other psychiatric morbidities. they smoke early, they use too much pot, they have obesity issues with obesity that start in childhood, they have type 2 diabetes, and the genotype, clearly we show that there is a genetic underlay to all of these issues. So this is from one of the authors of the study, and he says, this study reinforces against deniers, and I know pediatricians know all about deniers, especially related to vaccines, against deniers, the idea that ADHD is a disorder with a solid biological basis, and genetics mean a lot. This is a massive study. This is, to me, is a practice-changing study showing that these disorders, the phenotypes that we see in all these different patients, that there's clear genetics underlying this. This is not like a couple of patients did a little bit of a swab and got their DNA. 10 million different segments of DNA. You guys, I know the different biological or neurobiological underpinnings of ADHD with working memory. We know that there are the cingulate is important, abnormal neurotransmitters. It's all about executive functioning, right? Your prefrontal cortex, your working memory. They also have an abnormal reward system. They have an abnormal alert system. But what you might not know much about is myelin dysfunction in ADHD, which is another cool area of research. So what appears to be the case is that either delayed or dysregulated myelination may underpin ADHD, the neurodevelopmental aspects of ADHD, but more importantly, why for some kids it persists into adulthood. Because we know it's not everyone. Like 15, well, it depends. Like there's a million different, the numbers are between 15% and 65%, but it's all how you define persistence. But even if you're at the most conservative 15%, a lot of people still have symptoms that impact their functioning. And one of the questions is, why does it persist? And this is some of the first evidence showing maybe this is what underlies the persistence. But we also, if you think that, if you look at this data and you believe that it makes sense and it's valuable, it also may be an opportunity for intervention. So when you go to a big schizophrenia meeting now, OCD, bipolar, they're called circuitopathies, right? Circuitopathy, so a disease of the circuits. And you know, when the Canadian Pediatric Society came out with this recommendation, you shouldn't smoke pot till you're 25, that's because your prefrontal cortex isn't fully formed until you're 25. And during your teen years is when all of these critical circuits, these superhighways between your prefrontal cortex, your amygdala, and different brain areas, this is when they're really formed. It starts all through life, right, when in utero, and you're pruning and you're specializing, but those teen years, that's when those circuits are really most critically formed, and that's when schizophrenia first presents, that's when bipolar first presents, those most serious illnesses. So the myelination starts in the third trimester and continues through, and those oligodendrocytes, of course, are what make the myelin, and they're so important for those neural projections, the ability of neurons to talk to each other. So I've shown you there's a gene that's coded, that's an important fragment in ADHD, and now we're showing that oligodendrocytes, which create the myelin that allows for their neuronal connections, also appears to be abnormal. And that might actually be where the genetics starts and causes this lack of appropriate neuronal connections. Neuroplasticity, everyone knows what that is, the constant wiring and rewiring of your brain that happens. It's how you learn new things, right? It happens all through your life, but peaks around 25, 30 and goes downhill afterwards, right? We're slower to learn new things. And remember, there's good neuroplasticity and bad neuroplasticity. Good neuroplasticity would be, I decide I want to learn how to dance. And I have, believe me, no dance skills. So I go to learn how to tango. Every time I go to that tango, I don't even know how to start to tango. Every time I go to that class and I learn a few steps, what am I doing? I'm wiring my brain to say, this is how you tango. And every time I go to a class, I got a little bit of wiring going on, and I'm building on that wiring. By the time I get to class 10, I don't even need to think about class 1 because I wired that, right? Neurons that fire together, wire together. So the more you use those neurons and those circuits, the more they work for you, right? Anyone drive a standard shift car, right? You haven't driven in forever, and you get in a standard shift car, and you're like, oh my God, how does this work? And then you go, okay, I'm just going to lean into the standard. And before you know it, because your brain is wired for that. That's good neuroplasticity. All learning, neuroplasticity. Bad neuroplasticity. Say I have OCD. And so my compulsion is to check the stove. Every time I check the stove, I am reinforcing the wiring that says, check the stove, right? I know very well I don't need to check the stove, but the pressure builds and I got to check the stove. Gives me relief and then it builds again and I reinforce it. What is the CBT that has the most empirical evidence for OCD? It's called exposure and response prevention, right? And what is that? Diane needs to stand next to the stove but not check the stove. Every time I don't yield to the compulsion to check the stove, my brain is wiring to say, you don't need to check the stove. That's how CBT works, right? That's good neuroplasticity is not checking. Bad neuroplasticity is every time I check, I'm reinforcing it. Okay, so ADHD, circuitopathy, there's a damage to that circuit, and part of it is that we're not making good connections between neurons. So this is an fMRI. You all know what that is. You're in the MRI and you got to do stuff, right? And then they look at how your brain works. Symptom recovery in ADHD is related to stronger connections in your cortical regions, in your executive networks, right? We know that if you recover from ADHD, they can look at how your networks are working, your executive networks, and they're stronger, they're working better. So if you have higher connectivity in your frontal control region, you see decreased ADHD symptoms. The pattern and strength of resting state functional connectivity, which is what they're testing with this fMRI, doesn't matter the kind of ADHD you have. This reflects the fact that we do create compensatory or compensatory neural networks that aid in symptom remission. What does that mean? When you have ADHD, you grow. That's why a lot of adults, their brain develops, and they develop compensatory mechanisms. Let's go back to Robert for a second. So he comes from a loving and supportive family who totally gets mental health, mental illness. He's 22 now. The boy knows right from wrong. But sometimes he does things that you go, oh my God, right? Somebody put a flyer on his car and he was upset about it and he ripped it up and he's exploding and then he comes home and says, oh, I told that guy, and his father and I are going, what? Oh my gosh, why did you do that? You know you shouldn't talk. He was an older man, there was no reason to do that. And then he feels guilty, he feels ashamed, right? But with time, I'm hoping his brain will develop. He'll decide, I feel awful doing that, so he's going to be reinforced, there's going to be neuroplasticity. I don't like how I feel afterwards when I really think about what I've done wrong. Eventually, he will develop those compensatory mechanisms, and he responds to his parents talking to him and saying, you know that's not a good thing to do. What he doesn't respond to? Yelling. Do not, you know this, right? Yelling at a kid who has ADHD does not work. No child, I don't know if any of you have teenagers, but you know their prefrontal cortex is not fully formed. Yelling at them does not seem to do any good. You just have to tell them again and again and again. So the question is, because this kid's growing, he's got loving parents, do we really need to treat ADHD if eventually, for the most part, kids' brains grow? Well, what medication does for Robert is allows him to touch that pause button, right? It gives him a minute when he is appropriately treated to go, wait a minute, I got other ways of dealing with this. It's not fixing, and I don't think we have evidence that ADHD medications fix ADHD. But what they do, I think, is they keep kids out of trouble. They allow them the time to hit that pause button and look at alternative opportunities. Now, parenting, as a psychiatrist, my job is primarily teaching people how to parent, and man, do I believe that that is one of the most important jobs all of us do. Social reinforcement, what his friends are saying, what other people are saying, and his brain is going to continue to develop, and he is going to create these compensatory mechanisms. So what about long-term stimulants? Are they safe? Do they even make a difference? Why are we using them? Well, there's a lot of data showing us that these drugs can be helpful. This is, I just listed a bunch here, enhanced orbital frontostriatal white matter connectivity, therapeutic oral dose of stimulants, decrease alterations in structure and function. Preliminary evidence shows there's more normal activation on long-term stimulants, but Here's a large, well-matched study, and this is a brand new study in 2019 saying there's no evidence that it helps in the long term, but you know what? There's also no evidence that it harms in the long term. It doesn't change some of these major issues like ADHD symptoms, social emotional functioning, motor control, but does it give your kid, when they're developing, time not to get in trouble with their friends, not to do some of the major things that lead to trouble in the long term with ADHD? What are the negative outcomes you may be avoiding with treatment? And there's a lot, right? This is showing from childhood to adulthood, accidents, injuries, traffic accidents, and then, of course, as they get older, those unplanned pregnancies. And now we have genetic evidence showing, we've shown the phenotypic and genotypic connections between being 15 when you have a baby instead of being 29. Underachievement at school, being expelled from school, then you're not getting into university, then you're reduced in your economic outcomes because you're not able to get the jobs, you end up with a lower socioeconomic status, emotional dysregulation, and look how it really spans the entire life of that kid, low self-esteem, lower quality of life. Suicidal ideation, suicide attempts are associated with ADHD. Have you seen the data about suicide in the US? It has gone up 30% in 10 years. Completed suicide in the US. This is not a little change. This is massive changes. I think it's social media, to be honest, is some of what is leading to the, is sort of associated with that. Poor social skills, impaired family relationships. You guys know this well. So you have that right from the get-go, and then you're getting divorced. You're having marital discord. You're not being a great parent, and you got a kid who has ADHD. So it's very difficult to parent that kid. And then we go on to the next levels of actual health problems, and I've shown you the neurobiological, the genetic underpinnings of obesity, type 2 diabetes, hypertriglyceridemia, up to premature death. There's data supporting all of this. And just you may have seen this before, this is a 33-year follow-up. So this isn't like, you know, they were 10 and now they're 20, what's happened. This is over 33 years showing all of the same stuff that now we have genetics to show that there is a clear connection with ADHD. So this leaves us with a question. Is the risk of treating ADHD with medication greater than the risk of not treating ADHD? And I think that's the question that you guys have every day when you have a patient in front of you and their family. We're offering you this medication, which we've been using for 70 years, but we don't have fantastic long-term data. So there's one other piece I want to tell you about before we get into treatment, which is ADHD associated with starting school early? Have you guys seen some of this data? Okay, so the ADHD diagnosis, as you know, is of course biopsychosocial, and you're supposed to have, with every psychiatric diagnosis, functional impairment, but not just in one place. Like, I fall apart every time I go to my boyfriend's house. That doesn't work. It's got to be at home, at school, in many different situations for you to have a diagnosis. As well, you guys, I know, depend a great deal on what teachers tell you, right? You have teacher scales, you have parent scales. Unfortunately, in psychiatry, usually I just have the patient who's come to see me, but this is why we in psychiatry need to do a much better job of collateral information. I need families or whoever you love in with you so I can get some collateral information. But you're relying on parent or teachers a great deal. When you look at the questionnaires, what do they say? You should compare the child to their peer. And if you look at the Vanderbilt teacher rating scale, you will know each rating should be considered in the context of the appropriate age of the child. But what do teachers do? I am the teacher of a grade 1 class. This kid is not behaving like a grade 1. Is that how we should be assessing someone who's in grade 1? No, we should be assessing them based on their age, not on the rest of the peers. Because what you guys know, right? You know, can they regard a raisin? When are you supposed to be able to do that? You know the age that these are supposed to happen. So a 5-year-old, whether in kindergarten, grade 1 or grade 2, is still a 5-year-old. And I don't think that we are necessarily talking to teachers about, think about a 5-year-old, and man, do they have the time to do that anyway? They're thinking grade 1, not about the individual kid. So when you look at the data, it's pretty convincing. yes, ADHD is associated with when you were born. There is more ADHD in kids that are born closer to the end of the school year. So if you look at the data, the cumulative incidence of clinically diagnosed ADHD is clearly associated with being in school, number one, and being born between September and December. The association doesn't matter, the type of ADHD, how severe the ADHD is, whether you got comorbidities, whether you're on medication. Clearly, if you're from September to December, the risk is greater. The relative risk goes up to 2, from 1 to 2. The association, however, is not exclusive with ADHD. All developmental disorders have the same data. It's not just ADHD, all neurodevelopmental disorders. And there are a number of large studies that have found the same sort of thing. Now, when I read something like that, I think, well, what does this mean? Right? Does this mean that you sent a kid, oh my gosh, I sent my child to school when he wasn't even 5 yet, right? Because he was king of Kensington and he was ready for school. We could not possibly keep this child out of school. Have I caused him to have ADHD? Because that's what the studies imply, is that if you keep your kid out, they're not going to have ADHD. That's what people who talk about these studies say. So why does school age matter? Well, we know, of course. If you're 5 and everyone else is 6, you're less likely to be able to self-regulate. You're going to be frustrating everyone. You're not going to meet expectations. The teachers are not going to want to deal with you. They're more likely to be able to report you to the parents, and the parents are going to the doctor and saying, what the heck is going on? However, if you have a disorder that was latent, and you would have seen it if you kept them out a year later, in a year you were going to see it anyway, what do we know about all psychiatric diagnosis? The sooner they're diagnosed, right, and managed, the less brain injury, the less likelihood you're going to have a comorbidity, the less likelihood you're going to have negative outcomes. So there's 2 sides to this coin. Now, the immature brain hypothesis is often touted as the kid was immature. If you kept them out for a year, they wouldn't have ADHD. But the immature brain hypothesis actually has a lot of science behind it. And what it is basically is the relative age and the actual age, what the classroom is like and what your actual age is, really is important when you're really little. As you get older, the difference isn't so important, right? But when you're really little, if you're 5 and everyone else is 6, there is a big difference. The hypothesis is supported actually by a great deal of neuroanatomical and functional data. I don't know if you guys remember that great study Shaw did. He did a couple of them where he was showing, I have these beautiful slides, I could talk all night, but these beautiful slides showing a regular brain and an ADHD brain, their cortices are thinner and develop more slowly, massively, like up to 5, 6, 7 years more slowly than kids who don't have ADHD. ADHD with worse outcomes, the kids who do less well, have fixed thinning of the prefrontal cortex. Those kids who have right parietal cortex that normalizes, and most do, right? Because 15% actually go on to have still persistent full ADHD, despite the fact that they had full ADHD before. Only 15% go on. And so if you have that catch up, which most kids do, this is why you see this normalization. They may still have symptoms and functional impairment, but they don't meet the full criteria. Now, there are some serious implications to overdiagnosing this disorder, right? You got kids who are started on ADHD medication, maybe for the rest of their life. They're going to be associated with, well, first of all, every kid does well. We all do well. Did anyone have coffee this morning? We all do well with stimulants, right? Everyone functions a little better. So most kids, if you stick them on, they're going to be able to pay attention better. But they're also going to be exposed to side effects. They're going to be exposed to perhaps stigma from other parents or the teachers or their other students. But you also might miss another explanation. There's actually something else going on, but we diagnosed ADHD, so that's it, right? So we need to pay attention to kids, especially if they're younger kids in the class, and really think about their developmental age, not the age of the other kids around them. We have to look at a 5-year-old like a 5-year-old, not as a grade 1 or a kindergartner. So what do? Number 1, your clinical expertise is the most important thing. We talk about the science, and I believe in evidence-based medicine, but you cannot treat anyone without clinical experience. That is as important as anything else. Unless your clinical experience is everyone gets a kale enema, then we got a concern. But if your clinical experience is, I've seen hundreds of kids with ADHD, and I know that this is what ADHD looks like. But also that you think about the child's age, not the grade. You consider all functional domains. And I'm really interested in knowing how many pediatricians, pediatric psychiatrists, if you know the data and you know the genetics, how many of them assess parents? How many do an ASRS? How many look at the siblings and do a screening on the siblings? Because when should your spidey sense be going, oh my gosh, I think this is ADHD? What's the number one thing? Family history. This is how I see adults a lot of the time, is they say, my kid, well, I see them with their bipolar, and then they say, you know, my son's got ADHD. Could I have ADHD? We do an ASRS, you do a clinical interview, and you go, okay, of course you have ADHD. So that doesn't take, like, it takes literally 7 minutes for someone to do an ASRS, you to take it back and review it and say, yeah, I think you may have ADHD, go see your family doctor. I think that but that is a powerful tool for you to say, I have more evidence here to make this diagnosis. The second last thing I'm going to talk about are the treatments safe. I know you've all treated a lot of kids with ADHD, or almost all of you have. There are literally hundreds of reports about whether these medications are well tolerated, whether they're effective. There's meta-analysis now. But I'll talk more about what expectations are of the medications. What should we be expecting from these? There's lots of data, but I want to show you this 2018. So this is from, I think, October of 2018. It's from the Lancet, so you know it's a very well-respected journal, a meta-analysis. And what they said is, to the best of our knowledge, our network meta-analysis represents the most comprehensive comparative synthesis to date of the efficacy and tolerability of ADHD treatments for children, adolescents, and adults. And they address some of the issues that were problems in other meta-analysis. So they looked both at published and unpublished studies. They took out crappy studies. They looked at all age groups as well. When altogether, there were more than 14,000 children and adolescents and more than 10,000 adults. This is a massive meta-analysis. And this is what they found. These are clinician-rated ADHD scores for children, adolescents, and adults. The drugs work. Clearly, the medication works. Modafinil, not so much, certainly for adults, but I never use modafinil for adults in this context. But the psychostimulants and the other ADHD treatments work. And when you look at parents' treatments of their kids' ADHD or adult self-rating, they look the same as the clinician rating. These medications work. And I'll just make the point that in this Lancet paper, nobody had any disclosures. Nobody worked for Evil Pharma. This was not a pharma paper. This is a peer-reviewed journal. And their conclusion was all of the drugs worked. They were all superior to placebo. And then they looked at core symptoms and why, you know, some work better than others. Some were in different groups. And also with respect to tolerability, for children and adolescents, only guanfacine and amphetamine were less well tolerated than placebo. Modafinil, amphetamine, methylphenidate, and atomoxetine were inferior to placebo in adults. What does that mean? When you're on a drug, it has side effects. And they're not as good as not taking a placebo. But are the side effects short-lived? Are they tolerable? Do they, when you do a risk and benefit analysis, are they worthwhile for that child, for social and educational opportunities that they may offer for that child? I'll just throw up, this is a brand new 2019 study that I just pulled out today because it was exciting that I had more data showing this is amphetamines, methylphenidate, the drugs work. This is another one. This is effect size. And remember what effect size is, the magnitude of effect. The likelihood if you give a drug that you're going to get the benefit you're looking for. Look at these effect sizes. Amphetamine, 0.99, methylphenidate, 0.7. These are huge. A small effect size is like 0.1, 0.2, medium, 3, 4, 5, 0.6 and up. That's a big effect size. And 1 is a mother effect size. Like this is a massive effect size. What else in medicine has effect sizes of 0.9? 1. I'll tell you what, Cialis. Not the natural, not much else. That is a massive effect size. But when you look at some of these other treatments, I'm actually shocked. Diet, 0.4. Wow. But a lot of the other treatments that are non-pharmacological, and you know we've seen data about, for kids particularly, that nothing works quite like like the treatments that we have, the pharmacological treatments. Interestingly, there's some really good cognitive behavioral data in adults. And probably a lot that underlies that is I never see an adult who doesn't have comorbidity. They all do, right? 50% of adults have an anxiety disorder, not just anxiety, but an anxiety disorder. 40% have a mood disorder. And the comorbidity, when you think about bipolar, 1, 2, soft bipolar, or NOS, that in the DSM they're called specified and unspecified, that's about 1.5% of the population, maybe 2 on the outside. ADHD in adults, 3 or 4%. If you have ADHD, what's your risk of bipolar? 20 to 30%. Why do they ride together? We don't know. They clearly have shared neurobiology, and we're going to get that data now that we have these massive data sets to understand. But we know that these co-occur very, very commonly.
Parent training minus?
Yeah, it really sucks, unfortunately. That, much to my surprise. Because I believe in the power of good parenting, but training parents make the... Okay, so now we have come to the crescendo of the discussion, which is unfortunately appears to be one of the major focuses of my clinical life. What does $15 million buy BC physicians? Because that's what the Therapeutics Initiative has received from the BC government, $15 million, okay? So these are some of the challenges facing psychiatry, and I know that we have a lot of shared experience with this, but in psychiatry particularly, we have no public confidence. Maybe a year and a half, 2 years ago, I was in an airplane. I was not flying the airplane. I was in the airplane, and I was reading the Globe and Mail, and they had a survey. What do we think of our colleagues? So it had physicians, practicing physicians, residents, and medical students. What do they think of their colleagues? If you lift a rock out, a psychiatrist may crawl out. Like, we are at the bottom. Sorry, you guys aren't that much over us. It's like psychiatrists, family doctors. We are at the bottom of the barrel. Flakes, non-scientific, not real doctors. You know, we do it to ourselves a little bit, to be honest. But the confidence in psychiatry is really very low. There's abuse of mentally ill patients in this province. I don't know if any of you heard what's going on in New Brunswick. They had a new psychiatric institution, 2015, rampant abuse going on there. The ombudsman got involved, and I mean, it was, and this is happening here. I had an experience at one hospital, and people, and I wrote about it in one of my letters to the newspaper, and people were asking me, you know, oh, that must have been this hospital. No. Oh, it must have been that hospital. No, wasn't there? Like, everyone believed it was every other hospital but the one it actually happened in. And when I wrote that in November, I got emails from everywhere. And it was very sad, actually. Almost all of it was very supportive. I would say like 99%. But the letters I got from psychiatrists, not just in BC, but across the country, the emails were so sad. When I spoke up for my patients, when I tried to advocate for my patients, I was blackballed. I was abused. I lost my job. So I was shocked because I believed that was going on, and these people wrote me and told me that. And of course, we know the access to care is abysmal. We also know that we're living in the age of, you know, anti-vaxxers, where now we almost didn't have measles and now we have it again. So people do not believe in medication. They don't believe in psychiatry. And rational psychopharmacology, what I'm doing with my psych, this is not taught. Why are psychiatrists coming to listen to a psychiatrist tell them how to use drugs? Because we don't do a very good job of teaching confident, rational prescribing. If I ask a group of family doctors, how many of you are treating hypertension with one drug? No one's doing that anymore, right? They're using 2 drugs, they're using 3 drugs, right? How many of you are using 1 drug to treat diabetes? They're using 3 drugs, 4 drugs. One of them is insulin. What is scarier than insulin, Dean? Right? You can kill your husband and no one would figure it out. It is a dangerous drug. They're using warfarin. But they are afraid of my drugs. And what's happening is, first of all, access in BC Pharmacare, we have the lowest access of new psychiatric medications in Canada. The lowest new access in Canada. And the Therapeutics Initiative is driving this. So what is the Therapeutics Initiative? They claim to offer unbiased advice about evidence-based drug therapy. These are quotes from their papers. They say that every review is submitted to 60 experts and primary care physicians in order to correct any inaccuracies and ensure the information is concise and relevant to clinicians. It is funded by the BC government. I can tell you, 95% of the people, God love you, are pharmacists on the Therapeutics Initiative. There are no psychiatrists on the Therapeutics Initiative. When I read the first one, which I'll show you in a minute, I did a rounds on it, and I tried to figure out who is on the Therapeutics Initiative. They had a website. There was nothing on it. They did not respond. They had no way to write to them. They had nothing about who these physicians are. Now, after I did that, now they have a website, and they've got some faces on it. There are not 60 people on there that they send this to review this information. And certainly, when you're throwing out stuff about psychiatrists, do you think maybe you should ask a psychiatrist? So these are some of the ones they did. This was the one I did the rounds on, the first one I saw. Antipsychotics should not be used for non-psychotic depression. Antidepressant withdrawal syndrome, I'll just give you a small nugget of that, which is anytime you give an antidepressant, it's very important that you advise them, not unlike you would if you gave them a long-term opioid. Right? Okay. Which I'm sure you're doing now if you're using antidepressants. Of drugs to avoid, including antidepressants and antipsychotics. And then this one that was from January, February 2018. And what their conclusions were, whether the benefits of long-term CNS stimulants for children outweigh the harms remains unknown. There is convincing evidence that that ADHD is simply an issue of kids being the youngest in their class. There's insufficient, so I'll show you the paper that they're basing a lot of this on, which is their own research, but they're saying there's insufficient evidence to know whether their research has had an impact on prescribing, but the recent increase in CNS stimulant prescribing in BC is concerning and unexplained. And they show this chart. So this is between 2000 and 2017, that the treatment increased from 2.4% to 4% of the population. So you guys are all very evil, because you're treating ADHD, and most of it is being driven by pediatricians and pediatric psychiatrists who do the initial prescribing and then ask the family doctors to continue in the long term. Are we adequately treating the population if 4% of kids are being treated?
No, because it's 7%.
Right, right. So in fact, these numbers are good because there's a positive trajectory, but there are kids who have ADHD that are not being treated. Not everyone needs treatment, right? And everyone's on their own journey. Every parent and family needs to make their own decision. But this, to me, is not a bad news story. So I'm just going to give you a little example from that. I got a million of them, but I'm just pulling a little bit out of this particular TI that's related to ADHD. So in this newsletter, they quote their March 2009 newsletter, number 773, that's entitled Atomoxetine for ADHD in Children and Adolescents. And they say, we recommend, without long-term RCTs, showing that atomoxetine improves educational achievement, school completion, employment, and future health, and in view of the risks of serious harm, use of atomoxetine should be limited to exceptional cases of kids who are intolerant to other ADHD drugs. That is written in their new newsletter. Okay, so why don't we just break down that paragraph a little bit, what they've done and what they've included there. The use of stimulants, they say use stimulants instead of atomoxetine, but don't you dare use stimulants, right? No atomoxetine, because man, we don't have the outcomes you need. Use another ADHD treatment, but don't use another ADHD treatment, because what they say in 2008 is better benefit and harm evidence is necessary before long-term stimulant treatment in children can be recommended. So they do not recommend you use stimulants, and they don't recommend you use atomoxetine. After a drug is developed, no one should use it, is what that's saying, because despite short and long-term safety data, post-marketing data, and years of clinical use, we have no evidence to show that a treated child will graduate with good marks, finish university, get a good job, and be a healthy adult. This is what they're saying. We don't have long-term data to show those things. If that's the bar we need to climb, we need to cross in order to treat kids with ADHD, no drug would ever be used. For heaven's sakes, you got to show that they have good marks at high school, get a good job, and are healthy adults. So the birth month study is what they're relying on, which is a study that they created. We suggested that poor and disruptive behavior among the youngest children in a classroom might be driving the rates of ADHD diagnosis and treatment, okay? This is what they're suggesting. You're going to love this one. This strongly suggests that teachers, parents, and physicians are medicalizing a social rather than a medical problem. This is in the 2018 ADHD newsletter that they sent to physicians across British Columbia. They called ADHD a social disorder. Impressively, that study that this birth month study was in the high impact Canadian Medical Association journal. This is what they're touting as this high power data that they have, and in quotes, the study received global media attention, was reported in many media outlets, including Time Magazine, the Globe and Mail, and ABC News. Well, I'm sorry, but if you're publishing data, you're doing a research study, and you're publishing data and sending it to my colleagues, you better send it to a peer-reviewed journal where you actually have some impact and you actually are viewed and reviewed by our peers, by our colleagues, not by a low-impact Canadian medical journal that commonly puts residence articles there. If you're actually trying to direct treatment in British Columbia, you better have a little bit of brass behind that, honestly. This is not medically sound. So I don't believe the therapeutics initiative is in any way medically or evidence-based. There are clear, I hope I have proven to you, there are clear neurobiological underpinnings to ADHD and that it is underdiagnosed and often untreated. If there are misdiagnoses, if young children are sometimes misdiagnosed, does that mean we don't diagnose ADHD? Because sometimes you misdiagnose other things. So probably no more strep because sometimes it's misdiagnosed, and ear infections, you miss those sometimes. That's misdiagnosed, so no more diagnosis. This is ridiculous. This is especially true in difficult to treat populations. Do we not diagnose kids who are the youngest in their grade because sometimes we're going to screw up? No, what we do is we make sure we do our very best not to screw up, that we're very careful in that population. We think about them at their age. We assess their whole family. We look for a family history. We monitor them carefully. And stimulant medications are the scariest thing for our colleagues. Yeah, we're good with insulin and warfarin, but psychostimulants, man, that's like, and some of them feel like it's like giving crystal meth, for heaven's sakes. They're not even the same drug. So what the TI does by sending this across the country or across the province is unnecessarily stoke that fear without evidence. The reason I know that is because at my Psyched Up, I got family practitioners coming up to me all the time with their therapeutics initiative saying, you just spent the last 3 hours telling me to use antipsychotics or psychostimulants or whatever, and look what the therapeutics initiative is saying. So I believe that the TI's biased approach, cherry-picking data, and that is exactly what they do on all 4 of those. They take pieces of data out. This causes death, and then they leave the rest of the sentence only if you take it on, with a massive dose of opioids, and they just say this causes death, and they pull that out and they put it in there. So they cherry-pick data without careful consideration, but even more importantly, without actual doctors who see actual human beings. There's no clinical experience. There's no representation of psychiatry here. That's it. Thank you. I hope you have questions.
Hi. What's the reaction from UBC?
Oh, you have to press your button. There. Oh, there you go.
The white ring.
Yes.
Oh, okay. What's the reaction so far from the university to your articles on this particular topic?
The one that actually provoked anything was the last one that you mentioned. I've done 5 articles for the newspapers, and every single one of them has had a whole page, and and not a single one have I had any feedback except nice article kind of thing. But interestingly, that one in November, I got invited to the BC Psych Association. The new president said, I don't know anything about the therapeutics initiative. So I went and I presented to them about that. And next week I'm presenting for regional rounds for UBC. That's the first time. And actually the person who's the head of psychiatry wrote to me and said, there's a new paper coming out about using antidepressant medication from the therapeutics initiative. I'm like, oh my God, not another new paper. Well, he was referring to one from 2017. So they're not recognizing what's happening across the province with people's reactions to these, because actually the newest one is the one about withdrawal syndrome. where they're saying giving an antidepressant is like giving an opioid. So I think hopefully I'm going to be able to engage, because when you have on your paper, we're from UBC, evidence-based medicine, and we're doctors, people pay attention. And so hopefully this is going to start to spark some change. Thank you for your question.
In 2000,
Did you press your button?
Yeah.
Okay.
In 2009, there was a lead article in the Globe Mail, a big article, and their big spreads. They've done a lot of research on, or study on it, showing the marked variability in diagnosis and treatment of ADHD across the country. Basically, in Quebec and Nova Scotia, you were twice as likely to be diagnosed and treated for ADHD as in BC.
Yeah.
How do you explain that?
It's a very good question, and I think that one of the reasons that psychiatry in general is viewed as unscientific and not at par with our peers, I think is related to the fact that we have as a group been slow to adopt. Well, first of all, we have no biomarkers, right, which is one of the greatest challenges. We have no objective tests. The best thing that we have available to us is using clinical scales. And, when I moved here in 2004, if I asked a group of family docs how many's using a clinical scale, I would hear crickets in the background. Nobody. The BC government, a couple of years later, decided we're going to pay family doctors to do a clinical scale. And not only are they going to get paid for doing that initial scale, they're going to get 4 extra visits with that patient. So instead of just 4 assessments, you get 8. And so now when I ask groups of family docs, how many of you are using clinical scales? Everyone is. They're using their PHQ-9, they're using their J87. So we in psychiatry, I don't know if it's arrogance or whatever, have not addressed and used algorithm-based care. We are not using clinical scales as we should, but as we are recognizing the importance and the power of that, I think that things are going to change. Also, the level of education, different schools, different teaching. I mean, I will never argue that we have awesome education in psychiatry. This is not an issue that this is not a mountain I'm dying on, because I'm telling you that this is not the case, and there is very uneven across the country. But what does it mean to you when you hear that? That there's more in Nova Scotia and BC, which, by the way, are the 2 provinces that I live in. So.
I've asked a lot of people that question, and I can't get a satisfactory answer. I mean, one of my first thoughts is that doctors in Quebec and Nova Scotia have a much lower threshold to prescribe medications than we do in British Columbia. My second thought was, well, British Columbia has a much friendlier climate. Most of the people live in the Lower Mainland, and it's a much friendlier climate. And there's lots of evidence that shows that if you're more physically active, you control your impulsivity and distractibility better. So that's my other thought, that maybe because we have a friendlier climate, people can be more active and kids can be running around more, whatever, they aren't as likely to be prescribed medications for ADHD. I don't know, but I have not got a satisfactory answer for that.
That's a very interesting comment, the friendlier climate. Are you a pediatrician? Mm-hmm. Yeah. How many kids do you see out playing outside their house and running around? Because, I can't get any human being that out doing anything, let alone away from their phone and away from. I think in general, the inactivity is a real problem. And I believe that exercise is a drug, right? It increases BDNF, it grows brain cells. It's a powerful treatment. And I agree with you that it is a benefit for depression, anxiety, every illness in psychiatry, and every physical illness benefits from exercise. But being from Nova Scotia, I can tell you that I don't think there's a big difference, honestly, in outdoor activity, because in the winter they're out tobogganing, they're playing in the snow, they're throwing snowballs. We had that last week or whatever. But I don't know that there's a big difference. And interestingly, while we have these, you're saying lower rates of ADHD treatment in British Columbia, but in Quebec, and because maybe it's related to the fact that we also have the least availability of medications. In fact, in Nova Scotia, we are the only province in Canada that has no long-acting stimulants for adults. We are the only province. And the last one, and Nova Scotia now has it. Yeah, but in pediatrics, we were also the last one to have long-acting stimulants. And even now, you have to prove that you've used a short-acting before you get a longer-acting one, despite the fact that we have all this evidence about the value of using long-acting stimulants. So, I think it's a very interesting question. I don't know the answer.
I don't know if there's any data that BC has high Asian population.
Sorry, Microphone?
Somebody else is still open.
Yeah, is this,
Does someone have one on?
Because I do see, I think in my practice, probably a bit more Chinese population, they're very resistant to medication.
I love that comment. And I would just share a quick story. My son's girlfriend is Chinese. And she, about 2 years ago, said to me, in my family, we're only allowed to have dermatological conditions. So that was interesting. And I sort of put that away in my brain. And then last year, there was a lovely family practitioner, Chinese family doctor, and she asked me if I would see her child for ADHD. So certainly. So they come to my office, and and the daughter, who's 17 or 18, wants her mom in with her, which is fine with me, and more the merrier. And so I interview the daughter, and my spidey sense is going. Okay, there's something more going on. So I asked the daughter, anyone in your family have any psychiatric mental health issues? And she says no. So I turn to the mom and say, do you know of anyone in your family that your daughter doesn't know about who has a mental health issue? And the mom says, no. But my spidey sense is pretty good. I've been doing this for quite a while. And so I say to the mom, I swear this happened. She's sitting there and I said, are you sure? And the mom sits sort of quietly for a moment and then says, I think that my husband's mother has schizoaffective disorder. What? So my point being, there are cultural differences. You got to dig around with different people, and there is a lot of resistance in different communities. So I think that's an excellent point, is that we do have a very large Asian population, and the idea of of treating ADHD is not on the spectrum. Also, what is the difference of ADHD in the Asian population as far as from a genetic perspective versus a Caucasian population or other populations? I don't know the answer to that.
So I see a lot of children who have prenatal drug and alcohol exposure. They have tremendous paradoxical responses to treatment. So they have, whether it's paradoxical or just unexpected. And so it's that interesting interplay of genetics, epigenetics, kids in care. There's just a lot to dissect, and sometimes it's difficult to know whether to keep trying to tweak and fix the pharmacologic route versus taking a step back and looking at the big picture. So what are your thoughts on some of these complex kids?
Yeah. I completely agree. And I would say so I have the 17 to 22-year-old SAT and then everyone else. And man, this is why I left pediatrics. I don't love parents. And that population is very challenging. So I use a lot of lamotrigine. And in adults, I've been accused of giving placebo in the past. It is an excellent, well-tolerated medication. If anyone's going to have a problem, they're 17 to 22. So just the younger population, they respond to medications differently. And then, then you add on these what I would believe to be brain injuries associated with early substance abuse, maybe even epigenetic underlaying of changing gene product. What my approach is with because I got a lot of complicated patients as well, is start low, go slow, and try each thing one by one. And people want to be better like that, so it's very difficult. And when your population, they're already kind of resistant to my population too, but especially in kids, resistant to being on medication, and now we've got to try all these different ones. So, but I think you're probably doing that. We'll try this and go up. And the 30-30-30 rule of medicine applies, I think, in psychostimulants. 30% only methylphenidate, 30% only dexamphetamine, lisdexamphetamine, 30% it doesn't matter. So most of the time, the first thing you choose, 66% of the time, you're gonna choose right. But then there's also the delivery and whether you got a big burst or you got the slow. Oh, yeah, they're complicated. I agree.
Thank you for the wonderful presentation.
Sorry, I think I'm next in line.
Oh, sorry.
Oh, you have a question, and now I'll come back to you, because I know you've been very patient.
For a WebEx participant. So what do we do with the media stories of high school and university students seeking medication to get better grades, as opposed to the real ADHD, and find a reasonable way forward in finding the late diagnosed?
Yeah, it's a tough question. And some of the pediatric of my pediatric psychiatry colleagues say, you know what, it doesn't matter. Everyone does better, and it's okay to be on a psychostimulant for anyone, and we all take stimulants. I worry about that because of the fact that I think it really does have a negative effect on the way people view the diagnosis and the treatment, and it makes it so, you know, everyone has ADHD. I think it diminishes the power of the importance of this neurodevelopmental disorder. My job is not as a police officer. I don't view myself as that. If someone is concerned about that, you give them small amounts. You know, no drug-seeking person who wants to sell to his high school is going to come do part fills and come back every couple of weeks and get more. They want the big burst of medication. So you will be passed by quite quickly. But that's how I try to manage is by small numbers, only part fills, making people keep coming back if I have any concerns. But I think that university treaters, they have the biggest risk. Someone comes in and says, I'm going to fail my exams. I took my friend's ADHD medication, and you know, for the first time in my life, I can concentrate. I have ADHD, I know, and my exams are next week, and I'm going to have to drop out of university. Can you treat me? And half of the people that I ask that question to say, no, I would not treat. But that's a tough question, isn't it? Like you get the history, but the person could be lying to you. So what's your job there? I don't have all the answers for sure. My answers are, let's stop the therapeutics initiative, and I'll leave the rest. It is a tough question for sure.
Two simple questions. One is with the legalization of marijuana, what would be the second-hand smoke implications on the adolescent and the developing brain?
There's only a small question there. Thank you very much. Well, I am a real believer in that THC is actually a neurotoxin. It's not your grandma's pot anymore. What was 1 to 4% in the schoolyard is now 25% or higher. If you're using shatter, which of course the THC is extracted with butane, we're talking like 85% THC. And of course, because we want repeat customers, the CBD has been bred out, which is the antipsychotic effect. If you look at the data, it is frightening. And in the Huffington Post, never read comments. If you ever write anything in the public, never, ever read any comments. That's when I learned, because I did a Huffington Post number of them on cannabis, and I referenced it up the yin yang, and I was getting these horrible, you know, you're a doctor, how embarrassing, quack, quack, quack. Didn't even reference it. But there are literally like not just dozens, like tens of references showing the early onset of schizophrenia associated with high potency cannabis. So this is, I think, a toxic drug to a developing brain and causes circuitopathy in a vulnerable brain. And the problem is, who's got a vulnerable brain? If you're in my office, your kid's got a vulnerable brain. Because if you're in my office, the jig is up. You got a mental illness, your kids are vulnerable. But there's a lot of people out there that don't have a psychiatrist and aren't seeing anyone, but they may carry genes for depression, for bipolar, for schizophrenia, and we don't know who they are. The other scary part about this, and it seems like most of you when I said epigenetics know about this, that now we know that by smoking, you can cause a change in your genome and how your genes are expressed. So you're a younger person, you're smoking, you cause an epigenetic modification that you transfer to your child. And your grandchildren. Of course, you care about, the most important is your grandchildren. When I first learned about epigenetics, it was, I was in my car, dropped my daughter off for soccer, and it was on Quarks and Quarks. Have you guys listened to this on CBC radio? And the guy is a geneticist, and he's talking about lung cancer. And he says, do you notice how we're seeing more people die of lung cancer who have never been exposed to any kind of carcinogen? Superman's wife, you remember Christopher Reeve? His wife was like a kale-eating, healthy, Lululemon wearing, never exposed to asbestos, never smoked in her life, and she died of a very virulent form of lung cancer. Why? And he said epigenetics. Probably her grandfather or father smoked, caused a genetic modification, that got transferred to her. She ate too much kale, turned on that gene, and then she had and had lung cancer. So we see this. There's now data with, I love kale actually, but that we now know that you can't do anything now without getting in trouble because you can, and cannabis, there's data with epigenetic modification that you can pass on.
So how do you protect these kids?
This is a great question, because when I moved to BC, I was struck by how many people think cannabis, it's like oregano. Like, add the little spice to life, you just add it to everything. And people were smoking with their kids because they thought, well, alcohol is dangerous, cannabis is safe. So I'm having turkey dinner with people, and we usually in Nova Scotia pass around, have a glass of wine. They're passing around a joint at the turkey. And I'm thinking, this is a different kind of lifestyle. And so in my office, I'm telling parents, please talk to your kid about the dangers of cannabis. And they're, what? No. I've been telling them that they should smoke. And they're saying, well, cannabis is safer than alcohol. To me, is like saying cocaine is safer than heroin, so let's use cocaine. They both are risky. And if you have a developing brain, nothing is more risky from an illicit drug perspective than cannabis. When you have, the data is really, or THC, not CBD. CBD is exciting. Something's going to happen there. But THC is, I believe, a neurotoxin. So we got to talk to parents. That's the only way in, I think. And early. I'm all about scare the bejesus out of the children, so I'm fine with that. So.
Sorry. Diane, thanks so much for your work at pushing back against the TI. Like, as a pharmacist that works in the health system, I'm frustrated because I can't write about it, talk about it. But I think it's not the whole picture. You're not getting peer review, and how can you be unbiased when you're the payer for drugs in this province and you're paying this group to make comments about drug use? You just can't be unbiased in that situation. Thank you for your work and all your letters.
Well, that's an interesting comment. Thank you so much, Dean. The word bias, because they use unbiased, right? As if I'm biased because I use these drugs, or I give talks for pharma. And honestly, if you go to my talk, you should not know what company has asked me to speak, because what I sell is illness. Treat the illness. I don't care how you treat it, but make the diagnosis, follow algorithm-based care, use clinical scales, and treat the diagnosis if it needs to be treated. They don't consider that they have a bias. They have an anti-medication bias. Now, I'm talking about psychiatry because that's all I can deal with. They don't like, do you know the only drug that they have had anything positive to say about? Iron. And iron deficiency anemia. That is it. Like, every other drug is no good.
I thought they were big on metformin too.
Oh, was there a good metformin one? And it's not just like I've been writing about this, but in my little research, I saw there's some rheumatologists who have written, there's some respirologists who have written saying, this is bunk, this is garbage. Ophthalmologists. So, but when you've got UBC, professor, and the weight of $15 million, man, you can, and the worst part about it is, I got this, I don't know if you saw this or not, they have a relationship now, what's his name, Adrian Dix now, has created a relationship between Therapeutics Initiative and Pharmacare. So they are going to review therapeutic areas, 4 or 5 therapeutic areas every year to determine what Pharmacare should cover. That is in a position paper. I don't have it in this slide yet. What? These people, they're like, so they're not treating. The guy who's the head doctor is an internist. And I think there's a couple of doctors, and there's no treaters other than those guys. And they're not like, they're making comments on my illnesses without any specialist. Oh, the worst part was, I got to tell you this. So the first one I reviewed was antipsychotics should not be used in non-psychotic depression. And let me tell you, they misquoted papers. I took quotes from there, and it would say, the authors concluded blah, 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 blah. And then I read every single paper that they reviewed. The authors did not say that. Like, they lied. They frankly misquoted the papers. It was unbelievable. So anyway, I was looking because I was doing a talk, so I went back to look, and I see they have a podcast. So I thought, I'm going to listen to the podcast about this therapeutics initiative. And I go on, and there's the doctor, and he's talking to this guy. He's introducing everyone. And you're not going to believe who the psychiatric representative was. I swear to God. Craig, the medical student. That was the psychiatric representative. And he says to him, Doctor, I can't even remember his name. See, I put it out of my mind. He says to him, So what are the outcomes you're looking for when treating depression? To the medical student. And the medical student goes like this. Now I am exaggerating. Oh my God. I was like in Emerge, and like this old man came in, and oh my God, he was on Seroquel. And I was like, I learned in second year, like that's an antipsychotic. And I was like, oh my God, that is the psychiatric representation for the therapeutics initiative. Craig, the medical, or Greg, whatever, Craig or Greg. Seriously, and that's why I wrote there, you know, that's like me saying neurosurgeons, they don't know what the hell they're doing. I'm just going to go in there and do neurosurgery, or, you know, those pediatricians, you know, what do they know about croup? I know I'm going to write all about croup when I never see anyone who's got croup. This is what they're doing. Psychiatry, we're a bunch of quacks, and we're going to tell you how to do it, and your drugs are useless. And in fact, ADHD is related to a social issue, and what are you wasting your time with?
What would be the medical legal implications if somebody were to have a side effect and they quote therapeutic initiative?
What is the
medical legal impact if somebody has a side effect and the lawyers quote, okay, this is therapeutic initiative, is a respected, so-called respected body is saying this.
Yep.
So how come?
Well, this is an interesting question, because they could be relied upon.
Right, right.
Well, first of all, they would be shredded in a court of law if someone used that, right? Because they're lying. The news, and I don't know if I'm going to get sued for slander, but I'm not worried about it because I read all the papers, and what they're saying they said isn't what they said. But it was interesting because I called the college and said, these guys are spreading this information about my specialty and the treatments that I use every day, and this is terrifying my colleagues. What can you do? And what did they say? Nothing. Because you can't complain, you can't make a complaint about something unless a patient complains, unless it's about a specific patient. So you can't go to the college and say, these guys are outside of their area of expertise, right? I'm not allowed prescribing antibiotics because that's outside my area of expertise, but they can opine about all kinds of treatments they know nothing about, send it to physicians across the province, and the college will do nothing. Yep.
How are they getting away with not doing like a systematic review with a proper?
The clinical librarian.
Yeah.
How about that?
Good question.
Start.
I don't know. I'm going to do this rounds with I don't know what it's called. I just agreed to go, and they're somewhere at UBC, and I'm going to present all the different papers, and I'm going to ask them that question. Who is going to stop this? This is wrong, and it is dishonest, and I don't understand how no one is paying attention. But when the head is saying to me, there's a new one coming out, and it's been out since 2017, I don't think people have actually understood the impact of these. But what shocked me was the number of people that were commenting to me about them, so I know it's frightening people. Right? I'm off the mailing list now, so I figured I just didn't get it. I didn't get it, so I said, could you send it to me? And he said, it's the ones about drugs to avoid, and that's a couple years old. So, yeah. Well, thank you very much for your attention, guys.